So welcome you all to this GIST track now. We're now here for an update on the part of GIST, and we have our first speaker is Professor John Trent from Florida. And I warmly welcome you, although the weather here is probably not so good as in Florida at the moment, but you're now navigating us through the therapy, and then we'll hear about wild-type GIST and other things in the second part after the break. So the stage is yours.
Thank you. Thank you for the introduction, and thank everybody for joining this session. It's really great to see so many familiar faces and talk to people in person I haven't been able to talk to in a long time. So thank you, and thank you for inviting me to discuss this topic. And so this is a broad topic, and I'm gonna share with you at least our approach at Sylvester for GIST patients. I'll start with just a little bit of background. I'm not going to go into a lot of detail, but okay, there we go. Okay, so GIST it's rare. We know it's rare, 4,000 or 5,000 new patients per year in the US. We also know it's one of the more common GI sarcomas. It may be the most common sarcoma as far as we know. We also know that there's a high frequency of metastatic disease, even patients diagnosed with a primary tumor, and that gene mutation really drives the phenotype in this disease. And GIST has really, I think, helped the world learn a lot about solid tumors and solid tumor biology, particularly with these very strong driver mutations. And metastatic disease is typically treated with tyrosine kinase inhibitors. And just briefly touching on a little bit of the molecular biology, KIT is the most common mutation. There's others we'll talk about. The most common mutations in KIT are in exon 11 or exon 9, and these activate the kinase such that when the kinase is turned on, it sends a signal and drives this phenotype, which covers many aspects of tumorigenesis, turning a normal cell into a cancer cell. Many of these cancer properties or characteristics listed here are driven by KIT, and these go away when you inhibit KIT, for instance, with imatinib. All of these processes can be shut down, and it's a very effective therapy. And again, in solid tumors, this paradigm of treating a kinase with a kinase inhibitor has let us learn a lot about not only treatment, but the biology, mechanisms of resistance, the radiographic imaging and assessment of response. It's really, GIST has really led the way in understanding a lot of this. Imatinib, of course, was the first medicine used to treat patients with metastatic GIST, now in the adjuvant setting. But there's been a number of other trials with other kinase inhibitors, sunitinib, regorafenib, ripretinib, avapritinib, particularly in PDGFR mutated, we'll discuss D842V, but also effective against non-PDGFR and PDGFR non-842V GIST. And I'm just showing some numbers up here where I have PFS, and that's basically like it's basically an average amount of time patients are on the study drug, or about half of patients are on that time, meaning half the patients are on it longer. And we know with imatinib in the metastatic setting, 24 months is like the median. But we all have the GIST clinicians. We have patients in our clinics that have been on imatinib for 20+ years. So it can be very, very effective in some patients with metastatic GIST. And so that's a median. And a lot of these studies were also done in very advanced states of disease, which skews the time patients are on study. So from our experience, and I think I believe most of the GIST centers, the numbers are a little bit, if not a lot better than this. But, and this is mostly KIT data. But like I mentioned, KIT's not the only, it's not the only player. There's other players in this scenario, other kinases, other mechanisms to turn normal cells into cancer cells. And this is a list that we discuss commonly about the GIST molecular subtypes. There's some new ones, for instance, that are not on here. FGF receptor has been implicated recently, but these are the most common ones that we see in clinic. And these are different, they're different genes, different proteins. So it's not surprising that their treatment is going to be a little bit different. Sometimes different drugs, sometimes different doses, sometimes different approaches completely and altogether. So it's critical to understand these subtypes. We did a study a few years ago looking at the National Cancer Database since mutation data has been incorporated into it. And what we found is with patients with metastatic GIST, only about 30% were having any type of KIT mutation testing, meaning 70% of patients were being treated blindly, which makes no sense at all. And I talked to my colleagues in, for instance, breast cancer group, they would never give a HER2-directed therapy without having proof that there was HER2 amplification or activation in some way. Ever, wouldn't be allowed. And in Belgium, Patrick Shofsky's helped the government set up a situation where you can't get the drug unless you have mutation testing done. And so that makes a lot of sense, but in the US, that's not the case. This is some older data, so we're seeing more testing now, but we're still not seeing the level of testing that we want to see in patients that are referred to our center. And so in addition to testing on the original tumor specimen, which we've all been advocating for many years, we've also been advocating for doing a blood test, which is sometimes faster, it's less invasive, a biopsy is not required, and that's called circulating tumor DNA. And so tumor cells have their own blood vessels, and these blood vessels are somewhat leaky. And tumor cells turn over, 2 new ones show up, but one of them dies and releases DNA. The DNA gets in the blood and can be tested for. And that DNA can be tested just like DNA taken out of a tumor from a biopsy or a surgical specimen, and sometimes most of the time can identify the driver mutation and other mutations sometimes that contribute to the patient and the patient's well-being. And so in our center, KIT and exon, we've looked at our data, and KIT and exon 11, KIT exon 9 are the most common driver mutations. We are able to detect PDGF receptor and other driver mutations as well. Although this test is not 100%, sometimes you don't detect any DNA at all, and I'll show some of that data later. But most of the time you do detect the mutation, and in the absence of having mutation data, maybe not subjecting patient to another biopsy, this is a reasonable way to understand the driver mutation. And it's important because patients, for instance, this one with a KIT exon 9 mutant GIST, on the far left, you can see a tumor by the red arrow. The patient's treated with standard dose of imatinib, has progression. And then we saw the patient escalated to 800 was the first thing we did. And the patient had a great response to therapy that was durable. And this is, we're not just making this up, this is based on data from the phase 3 400 milligram versus 800 milligram study. And so this is what we do in our practice with exon 9 mutant GIST. Sometimes you find rare tumors like this one that has this patient whose GIST has a mutation in a gene called RAF. RAF is another kinase similar to KIT, similar to PDGFR, but it's in the middle of the tumor cell, so it's somewhat different. but it still signals down similar pathways to turn normal cell into cancer cell and to drive all of those things we talked about, such as proliferation, survival, invasion, metastasis. And so it's not surprising, at least I don't think it is, that if you know the patient has a RAF mutation in their tumor and you treat them with a RAF inhibitor, that you're going to see similar results as a KIT mutant just treated with a KIT inhibitor. PDGFR D842V has been difficult to target. We've known that for a long time, and avapritinib came around, and a previously completely resistant tumor to imatinib is now sensitive, just like a KIT exon 11 mutant GIST is to imatinib. Now the D842V mutant GIST, which before avapritinib there was no treatment for these patients, is now FDA approved to treat these patients. And this graph I'm showing, we call a waterfall plot. And so each downward bar is representing a decrease in tumor size. And the percentage is over here on this y-axis. And so you can see almost all of the patients except one at the time of this evaluation had a decrease in their tumor size. If you looked at the same data with imatinib, all of the bars would be going up. There wouldn't be anybody's tumor shrinking. And the same is for TRK mutant GIST. TRK is another kinase. It's activated by a fusion, but you see the same level of activity when patients are treated with the TRK inhibitor. One of our colleagues, Jason Siklick, has been doing a lot of work with John Blad and Andrew Blakely and a lot of people in this room to develop a better understanding of SDH deficient GIST. He found a pathway that was important in this type of GIST that's not caused by a kinase, it's caused by a metabolic deletion of a gene that regulates metabolism, and found a vulnerability to a medicine called temozolomide. And so he designed a clinical trial that we participated in, and this is one of the patients that has an SDH deficient GIST treated with temozolomide, and clearly showed objective decrease in patient tumor size. So temozolomide is a reasonable treatment for patients with SDH deficient GIST, ideally in the setting of a clinical trial. In addition to temozolomide, there was some recent data from a trial we participated with Priscilla Merriam and Suzanne George in SDH deficient GIST patients. And this is one of the patients on the study. On the right panel, you can see at the top of the arrow, you can see a white enhancing in the gray area of the liver, and then it almost goes away over time as you follow the arrow down to the bottom panel. And then again, we look at the waterfall plot, and most of the bars are going down, which means shrinkage of the tumors. And this is a medicine called rogoratinib. We have to practice these medicine, at least I do at home. I have to practice them before I give a presentation. Murnau had the hardest one. Nirogacestat was impossible for me to pronounce for a long time. But anyway, so it was from Dana-Farber lab discovered some susceptibility of SDH deficient GIST to signaling through FGF receptor. Not mutation, not amplification, not translocation, but actually signaling through that receptor. And it looks very promising. And this is data from this phase 2 study for SDH deficient GIST patients. Again, not a kinase. So patients do become resistant to the primary therapy. We've been talking about first-line therapies here with imatinib, with avapritinib. Patients do become resistant. And so doing ctDNA testing, we can oftentimes identify the mutation that's driving the resistance, not always. It has advantages of looking at a metastatic landscape. So you get some DNA could have come from many different tumors. When one does a biopsy, it's a little more risky. It's more inconvenient for the patient. And it also will only give you information about the one tumor that you biopsy. So So we like doing ctDNA at our center anytime a patient with GIST has progression. And this is some of our data where we looked at exon 13 and exon 17. So those are the two types of resistance that we primarily see. It's like chocolate or vanilla. You've got exon 13 or exon 17. Exon 17 is a little more common in our population, and this is all comers because many of them have maybe already had sunitinib a long time ago. Other different reasons maybe. Exon 13 and 17 are mutations in two different regions of the KIT gene that inhibit the ability of kinase inhibitors to bind to it and turn it off. Some people use the analogy of imatinib binding to KIT and turning it off, like turning off a light switch. That's not exactly 100%, of course, but these secondary mutations prevent the light switch from being turned off. And they don't allow imatinib or the other kinase inhibitors to inhibit and shut down the tumor signaling. And so with our ctDNA data, collaboration with Cesar Serrano and Sebastian Bauer and other labs, there's emerging patterns of resistance. And so this is what we would call a heat map. And what we've found with ctDNA from experience and some of our various centers' data is that the exon 13 and 17 have differential sensitivity to the next tyrosine kinase inhibitor that they're going on. So that kind of rocks the paradigm. The paradigm prior to this understanding was that you put patients on a drug based on the order of the clinical trial that was performed. It doesn't make a lot of sense. There's no logic behind that. It's just the sunitinib trial was done in patients with imatinib resistance. The regorafenib trial was done with patients with imatinib and sunitinib resistance, et cetera. But this data suggests that maybe we don't just follow that progression of the order of the clinical trials, but we look at the biological mechanisms of resistance and treat patients based on their resistance pattern. So the key to this busy slide really is exon 13. So if you look at exon 13, red means resistant, yellow means sort of mostly resistant, green means sensitive. So if you look at exon 13, sunitinib is really the only one, and it's the one that's the most effective against patients that have an original exon 11 or 9 mutation and a subsequent exon 13 resistance mutation. Now you look at these other medicines, this is now bezuclastinib. If you look at these other medicines, they're not effective at 13, but they're more effective at the exon 17 resistance mutations. Some of these are I have 18 and 14 there, but I grouping those together with 13 and 17. So there are some subtle differences there as well, but this is the approach that we take in clinic now. If you have a patient who's progressed and has their tumor growing, and they've got an exon 13 resistance mutation that's driving that resistant in the tumor phenotype, why would you put them on regorafenib or avapritinib that has minimal activity? So that's the approach that we've been taking. And it was, there was some uncertainty at the beginning, but I'll show you a couple of patients. This is one of the first patients I treated using this approach. And this patient had this tumor, actually went on the avapritinib study, and the tumor did that really, really quick growth. About that time, we got the ctDNA back, and then we put the patient had an exon 13 resistant mutation. We put him on sunitinib, and she had a spectacular response to therapy that was durable over 2 years. And then here's another patient. This patient was actually sent to hospice and then called for a second opinion. And we, as soon as he came in, we did ctDNA testing. We found an exon 17 resistance mutation and put him on ponatinib and had a good response that again was durable for a pretty good amount of time. So these are just anecdotes. But we see this, it's not unusual in clinic to see this. And we've looked at our data, and this is some of our data on the utility. And so this is not a large number of patients. This is back from 2020. We published in 2020. We didn't have a lot of data at that point in time. But what we did find was that if you find a ctDNA mutation, driver primary mutation, in the blood, there's 100% concordance with the FFPE or the tumor tissue. The other thing we found is if a patient has a primary tumor or has low volume disease, ctDNA might often be negative. You might not get anything. However, if the patient has metastatic disease and a growing tumor and larger volume tumor, which we define as 10 centimeters of the 3 largest lesions, if they're over 10 centimeters and the patient's resistant, you have 100% detectability of ctDNA. But if it's less than that, we found 16% detectability. So if a patient has a 3 centimeter tumor that's stable, maybe growing very slowly, I might not do ctDNA on them because there's high probability it's going to be non-detectable. So how does ctDNA impact patient care? That's the next question. And so this is our data. And again, it's a small number of patients, only 39 patients. And we looked at the 12-month from ctDNA testing and looked at progression-free survival. And the patients that, and so on this curve, the lines are going across. Each downward deflection means a patient's tumor started growing again. As long as it's flat, the patient's tumors aren't growing. So the more downward deflections, the more patients' tumors are growing. And so this is, and so if you look at the data, and we're looking at progression-free survival in red and overall survival in blue. And so the data that we found was the progression-free survival rate was 46% at 12 months. And so that was encouraging to us because that's higher than one would expect in the general population without ctDNA. This was after our implementation of ctDNA testing. And so it did show us that there was probably a signal. So we worked with Cesar and Suzanne George and looked at the Voyager data. This was a trial comparing avapritinib to regorafenib in patients in third-line GIST. And the study didn't show that there was any superiority in all comers, but we wanted to ask the question, if you look at ctDNA, can you see any differences? And sure enough, yes. And so this again is data looking at progression-free survival. So each downward deflection means the patient's tumor is growing again. And so if you look at the patients with exon 13, so these are only exon 13 resistant patients, regorafenib does much better than avapritinib. So to me, it says, it doesn't matter what line of therapy the patient's on, what prior therapy they have, if their ctDNA shows that their resistance is driven by exon 13, we would treat with regorafenib over avapritinib. It's a little surprising because regorafenib, remember, is not that active at exon 13, but the difference is that avapritinib has absolutely zero activity at exon 13. And that can be evidenced in this slide. Also, these are patients without KIT exon 13 resistance mutations. So there's no KIT exon 13. Most of them are KIT exon 17 resistance mutations. And avapritinib, we know, works much better, works very well at KIT exon 17 and 18 resistance mutation, as well as PDGFR18, which is equivalent to KIT 17. And so we also looked at our data, and we looked at the second line plus patients with KIT exon 13 V654A mutation. And when those patients are treated, this is a retrospective review, not prospective, but when those patients were treated with sunitinib, they did twice as well as the patients treated with regorafenib when you look at the exon 13 group. And if you remember the data that I showed background from the beginning, sunitinib is about 6 months from the clinical trial was the PFS, and we saw 9.6 when the exon 13 subset was treated. So that's an area that's evolving. There's some prospective clinical trials evaluating that data. But we still need more drugs. Beyond using the same drugs in a smarter way, we still need new drugs. So there's another agent on the horizon that looks really promising called IDRX-42. And this are patients with imatinib-resistant GIST enrolled prospectively in this phase 1 study, starting at 120 milligrams, dosed up to 1200 milligrams. And again, you can see this waterfall plot where each bar is a downward deflection showing the percentage of decrease in the patient's tumor, size. And this IDRX-42 now has a lot of patients on it. It's only accruing patients to frontline now, no second line and beyond, only first line therapy. And it looks also very, very promising. Only a small number of patients are having clear resistance to IDRX-42. So we're optimistic about its development and future development for GIST patients. And the patients on the study had a 23% response rate. What that means is that 23% of the patients had substantial decrease in patient tumor size by 30% or more. And if you looked at the patients that had only had imatinib before, almost 50% of patients had substantial decrease in tumor size. So from these approaches, using our knowledge of molecular biology, mutation testing, ctDNA, we know that GIST subtypes can be associated with rational therapeutic approaches. And this is the paradigm that we use mostly. But what's next? There are a lot of clinical trials for GIST patients right now. We can all remember in the past when there weren't any. So it's a very exciting time for GIST patients. These are some of the trials. This isn't, I'm sure, comprehensive, but there's 4 phase 1 studies that are open right now. Ripretinib plus a DCC-3116, that's an ULK inhibitor. And so this is designed to prevent GIST cells from evading the death that's induced by ripretinib. And so it's a way to block the resistance and allow more GIST cell killing. DCC-3009 is a new KIT inhibitor. And then 3201 is an ADC, or an antibody drug conjugate. It's an antibody against KIT, so that antibody binds to KIT, but it's carrying a toxin with it. When the antibody binds to KIT, the tumor cell pulls it into the tumor cell and releases that toxin to kill the GIST cell. Another study is using a drug, a menin inhibitor, in combination with imatinib. Menin inhibitors have been very effective in some types of leukemia. Imatinib was originally, remember, developed for leukemia, so there may be some similarities in the action. This was the preclinical data was presented at CTOS last year, if anybody wants to see that. And then in gray here, we have some studies that have already finished accrual, but we're eager to see full results on that. We have a phase 2 study where patients with GIST prospectively who are resistant to imatinib or any other line of therapy are prospectively evaluated by ctDNA, and then we assign them the therapy that's most likely to result in benefit or response. And the ctDNA testing is provided for free. And there's a phase 3 study in gray, the bezuclastinib, sunitinib second-line study is already fully accrued. We're just waiting to hear whether it met the endpoint of progression-free survival benefit over sunitinib alone. And then there's also a ctDNA study for patients with KIT exon 11 mutation and exon 17 resistance mutation, where they're treated with either sunitinib versus ripretinib. I'd like to thank the sarcoma and GIST team, and thank you guys for taking time out of your busy schedule and traveling, for those who traveled, and listened to me ramble for a little while about GIST, but thank you very much.
So do we have any questions at the moment?
Jane.
I'm sorry if this sounds a bit of an old question. When you're talking about resistance mutations, and the reason I'm asking it is next to an SDH deficient patient, it's actually had stable disease for 9 years using Sutent. And now progressed, and I'm just wondering, do SDH deficient patients like that develop resistance mutations?
It's, to my knowledge, the mechanism of that type of resistance is not well defined. There's not any secondary resistance mutations for what I'm aware. The few times I've seen SDH, slow growing SDH deficient GIST start growing faster on therapy or not is when there are emerging mutations or activation of RAS, PI3 kinase, P53. And that's my personal experience. That I would love to hear from John Fletcher, who also have a lot of experience with SDH deficient and just resistance.
I agree. I mean, the patients that get faster growing tumors have a second hit, somewhere around
And P53, yeah.
And P53.
or others.
So would that be detectable by doing ctDNA testing?
Well, possibly, yeah. Possibly, yes. And let me just say, Jason Cyclic has looked at combining drugs like sunitinib with, for instance, a PI3 kinase inhibitor when the patient also has activating PI3 kinase mutation. He has a combination study that he's been looking at some patients on. So there may be a role in that setting. I would, if I have a patient with SDH deficient GIST, I would be looking at regorafenib and temozolomide. There's some data with sunitinib and regorafenib, but the data with these other two drugs, in my opinion, is a lot better.
He's progressing, he's been put on regorafenib, but he's progressing on that.
Regorafenib, and that or any FGF receptor inhibitor. So,
I don't know if we have access to any of those.
yeah, or temozolomide, or dacarbazine. I mean, you probably use dacarbazine. I don't know if anybody done that?
I haven't, but
Dacarbazine would be cheaper.
Are any of there was an FGFR inhibitor that was approved for compatible delivery and that was withdrawn.
Yeah.
Because, it had provisional approval. Which, if any, now are approved for some other type of cancer, not a sarcoma?
Yeah, we treated an SDH deficient GIST patient off label with erdafitinib, and she responded.
Is that the one that lost the approval?
I don't know the answer to that. It was approved when we used it.
yeah, right.
I don't know.
Amigatinib too. Another option there.
Amigatinib. Yeah.
Changing tack slightly. Where do you see these drugs in the adjuvant setting? So I was treated with imatinib for 1 year, then we had a brief for 3 years. Protection was not back after 15 years at all. And that's despite it, my tumor being my total count of 63. So most people said to me, it's not difficult. I'm nervous about how my MRI scan last week.
Well, the data with the imatinib is 3 years. There's some, at the end of last year, there was a study showing 6 years was better for recurrence, decreasing rate of recurrence, but the long-term outcomes of survival were the same.
What about any other drugs? Are they not been tested?
Not been tested. That's a question comes up often. It's a progression, adjuvant therapy, progression-free survival is not the most friendly endpoint. It's a more risky study than a late line, fourth line study in metastatic disease. There's so much variability, and it takes a long time to get the results too.
Yeah, getting approved on the, through the technology appraisal in the UK was tough. But that's that reasonable.
I would just also, I would also say for the SDH deficient GIST, since we don't have great drugs, we work closely with Andrew Blakely and other surgeons to resect disease when they can be, the patient can be, for instance, rendered radiographically disease-free. So we work with surgeons very closely. Yeah, or no?
Two questions. Looking into the future, do you see imatinib being de-seeded? So many drugs. How do you envision selection of drugs? First line, second line, so many things coming potentially into this.
Yeah, it's a great $1 million question. And, you know, I would love to be able to do a study, imatinib versus IDRX 42 or DCC 3009 if it emerges as very effective, even ripretinib, because they're very well tolerated. The IDRX 42 patients get a little dyspepsia, but that's almost it. It's even less side effects than imatinib. But it's a risky study for a company, I think, because the drug's effective and it's effective for a long time. So it would be a 8-year study probably to get to the endpoints, maybe longer. And so I don't know that a company's gonna do it, whether we should do it through Alliance or some national group, maybe. I don't know that they would have the appetite for that type of study either. And then the other possibility is maybe people just realize that these newer agents are, like ripretinib, are more effective. You know, their response rates are better than imatinib in front line. And so, and these are like the fourth line response rates. And so, you know, the other possibility is people might just migrate because it's better tolerated and we're pretty sure it's more effective. But that's a big step, you know, it's not something that we normally do in evidence-based medicine. I don't know, what do you think? How do you see it going? What do you think? Or anybody else? What about the patients? Would patients want something potentially to challenge imatinib in frontline advocates?
I guess my answer to that would be depending on the off-label element of it now, whether or not there's worse side effects coming from the off-label. So whether or not that would from the start. Yeah, whether that would initiate a program of. I was going to ask that question about off-label. Are you finding clinically within, you know, your cohort of patients on imatinib on all the other versions of it now, are they getting side effects that are worse, better, or is it about the same?
Or for the other later line agents, the side effects?
You know, the soft patent now, isn't it?
Well, you know, the side effects with sunitinib and regorafenib are worse than any of the other ones. But from my experience, ripretinib has fewer side effects than imatinib, even from my experience. And I've had patients in fourth line on ripretinib on it for a long time, much longer than I would expect imatinib dose escalation. Yeah, John.
That's a good point. Imatinib is on that.
Yeah.
So anybody know what imatinib costs now?
Well, in the US, you can get it for $40 a month.
Yeah. Yeah,
It's
so
35,000 a year. It was.
Yeah.
And that's the point I'm making, is the difference between all the off-patent stuff versus the original imatinib, where we're finding patients saying that they're asking for a different brand because they're not tolerated.
And looking just to Europe from a reimbursement perspective, you just made a point that imatinib is now cheap in many countries, looking also to countries of Eastern Europe and different areas.
it's a huge challenge to come with a first-line treatment in competition. So you must be tremendous superior with your effectiveness, because otherwise you don't have a chance to compete with a drug that maybe costs 300,000 euros.
It's not available in many countries. Yeah, still.
John.
I think I have another question about this ctDNA. Has anyone done studies where you look for ctDNA prior to radiographic disease progression, and can you pick up progression earlier with ctDNA?
Yeah, I'm not aware of any. I think there are some MRD studies in China where they're following ctDNA after surgery or on therapy. We looked at, so we collected, we were doing we were doing TDM, therapeutic drug monitoring, and we kept some plasma. And so it was only about 2 milliliters, but it was we had about 30 patients that we had 2 milliliters of plasma on, that we had the plasma drawn, and then the next CT they progressed. Okay, so it was like 8 weeks before progression. It was at stable disease, 8 weeks before progression. And in those, we couldn't even detect DNA. Wow. We couldn't even detect DNA. So that may be, the assay we were using. It may just be the way the biology is. It may be the fact that we need a more sensitive measure of MRD. I don't know much about it, but exosomes or some other marker that could predict radiographic progression prior.
There's a new study just started a few weeks ago in Germany, in Lübeck. Professor von Buchner, he's looking exactly into this, so we can share some information.
Is he looking at ctDNA?
Yes. Yeah.
Yeah, so it's, I'm a little skeptical because you have to have a lot of tumor.
Yeah.
And a lot of turnover, turnover, and it's different for other, like small cell lung cancer, Ewing sarcoma, can detect DNA much earlier.
The data you showed with a low percentage of patients with mutational analysis from years back.
Yeah.
Did that include patients who were like low risk,
Yeah.
primary tumors, all comers?
Smaller tumors. They all had a reason to have ctDNA, which we do when we're planning on changing therapy. Some of them had a primary tumor that was locally advanced. And those we found you don't detect any ctDNA. You have to have metastatic disease to be able to detect it. So yeah, it was a mixed bag of patients. But even in the Voyager study, only around 70% of patients had detectable ctDNA.
That was something I was wondering about, but I was asking a different question.
Oh.
The data just on all comers, but just then only 30% were getting a mutational analysis.
Oh, that data, yeah. The National Cancer Database.
Does that include patients who really weren't going to get a imatinib anyways, lower risk primary tumor, or?
Yeah, it was all comers, but what I show was the metastatic subset.
That was just the
Metastatic subset was 30%.
Do you have any idea why you have so less testing, or?
A lot of GIST patients are treated in the community in the US, and I suspect that it's community oncologists don't have time to come to meetings like this or CTOS or GIST meetings, and it's probably higher now. But I still see patients that are on imatinib that never had any ctDNA or never had any NGS or tumor testing at all.
Okay.
So it's probably higher, but I suspect and feel it's not as high as it should be.
And is this also the case in more common cancers like breast cancer or lung cancer, where
No,
this is a higher rate of testing? Okay.
I think so.
I found that an astonishing statistic. And I can only put it down to maybe the size of the country. Because in the UK, we'd like to think that most people get tested.
Is it
Otherwise, as you said, I do know what to treat.
So What do you think in the UK? Do you think just patients that are getting treated with systemic therapy have NGS?
I think all of them do. Because there are some clinicians who are mainstream, is specialists on the internet as well.
Yeah, it's one of
Because
the,
the move is to try and standardise it, that everybody does have it, and there's what the guidelines are coming.
it's one of the challenges to get people to recognise the medical profession in the UK to recognise that it is a specialist area, therefore they need to send them to a specialist centre.
We've got these genomic sequencing hubs now set up, so most people with that process.
I think the fault is probably even in the NCCN guidelines.
Oh, absolutely.
Right, that never outrightly said sequence these patients.
Yeah.
And that was a big fault, and I think the reason may be that every drug that's been approved has not been based in life.
Yeah.
But still, common sense dictates one, that if you don't have a good mutation, like why would you do something that can be actually an organ in a second? I'm not sure whether NCCN has changed their stance.
I don't think so. And even pathology guidelines, USCAP recommends mutation testing.
But I mean, that's, if you want to change things,
Yeah.
maybe reach out to NCCN.
That's a good idea.
I have an extremely important question.
Yeah.
Will you make the slides available?
Sure.
It helps for,
No
I've
problem.
got lots of stuff coming in, but good that slides.
Thank you.
Thank you.